Okay, good afternoon, everybody. Thanks for the invitation. We're going to switch gears a little bit. I'm going to talk about anticoagulation for DVTs. I don't have any relevant disclosures. So I thought a few goals of this talk would be first to just talk about which are the new anticoagulants that are indicated for acute DVT, and then what is the recommended duration of therapy, and then finally talk about some selection considerations amongst those agents. So I thought it might be interesting to just give a little bit of a historical perspective on how warfarin became initially widespread use and standardized care for DVT treatment. And you have to go back to the Lancet in 1960. This was the first randomized controlled trial testing warfarin therapy to placebo for treatment of DVT. And the premise behind this was that at that time there was no standard of care, and the cost of heparin was actually really high, and people worried about bleeding risk with heparin. So they randomized just under 20 patients in the untreated and treated group and found 5 mortalities in the untreated group and 0 in the treated. So at this point, they thought it was sort of unethical to keep randomizing patients. So they only continued to put patients into the treated group. So they built that up to 54 patients, still saw 0 deaths in the treatment group. So that's how warfarin sort of got started 60 years ago. And today, we have a number of novel anticoagulants that we can use: dabigatran, rivaroxaban, apixaban, and edoxaban. So the company sort of made it easy because now all of them have an indication for treatment of DVT and PE. And I'm only focusing on treatment. This is not prophylaxis. So I don't have time to go through the data on each of those agents, but there was a really nice meta-analysis that was published last year, and it basically groups the randomized controlled trials and the observational studies for all of these agents. And across the board, you basically see that there's very similar efficacy compared with warfarin for all of the novel anticoagulants. And in terms of bleeding risk, it's either comparable or generally superior to warfarin therapy. So this, coupled with the fact of convenience and not checking INRs, a number of people are now using novel anticoagulation. So that takes me to duration. So if you look at the 2016 CHEST guidelines, duration of therapy is split up into 3 sort of segments. One is in the first 10 days, called initial therapy, and then there's long-term therapy, which is 3 months. And so 3 months is sort of the new sort of target. So if there's ever a board question or anything that talks about duration of therapy and you're not sure, 3 months is probably going to be the right answer. And then there are certain situations, which we'll talk about, where you want to extend therapy beyond 3 months, and that is called extended therapy, and sometimes that could be indefinite therapy. So how long you treat depends on what the inciting event was and what the trigger is. So if it is provoked, for example, it could be a transient factor like surgery or immobilization. It could be triggered, but more of a persistent risk factor like a malignancy that's potentially curable, or it could be a more persistent trigger, and that could be sort of end-stage cancer or inheritable thrombophilias. So all of that impacts your duration of therapy, and it really comes down to what is the recurrent risk rate. So if it's a transient trigger like surgery, the risk of recurrence is really low, less than 1% at 1 year, 3% at 5 years, so the recommendation is 3 months of therapy, and then you can stop. If it's transient non-surgical, it's an intermediate risk of recurrence, but still the recommendation is 3 months. If it's cancer-associated thromboembolism, then the risk is much higher, 15% annualized, so you generally treat until the cancer is cured. And if it's unprovoked and you don't have an exact trigger, this gives you the highest risk of recurrence, 10% at 1 year, 30% at 5 years. Generally, this is indefinite therapy. So the anatomical location of the DVT also plays a factor in duration, but not on the other end of the spectrum beyond 3 months, but at the beginning. Do you even initiate therapy in the first place? And so if it's a proximal DVT, it's quite easy because those have a very high embolic risk. So even if you're asymptomatic and you pick up a proximal DVT, you should treat that DVT. If it's a distal DVT below the knee, there's a little bit of a debate because the embolic risk is much lower, less than half of what it is if it's proximal. And so the decision of whether to treat or not to treat could be based on symptoms, or if you have any of these risk factors for extension, then you might want to treat. And then if they do not have symptoms, then you don't have to treat, but then you should do serial imaging over that 2 weeks and look for extension. So generally, there's a lot of patient preference that goes into that if it's an isolated distal DVT, but the bottom line is that something has to be done, either treatment or surveillance. Just doing nothing is not an option. And the reason for that is because about 15% of those can still extend. And so you have to do surveillance if you're going to make a decision not to treat. So if you have someone who have a first unprovoked bleeding, but they're at a low bleeding risk, and you're trying to decide what to do after 3 months, do you need to continue or not? There's a lot of algorithms that include Ddimer. And so this is one sort of scenario where after your therapy is done, you recheck a Ddimer 30 days off of therapy. If it's negative, you're done. If it's positive, then you can treat for another 4 weeks and then check again. And it turns out that this strategy is sort of really gender influenced. And so men have double the risk of recurrence. And so this kind of algorithm using Ddimer is most helpful if you're dealing with a female patient. So I'm going to end with just a couple of selection considerations. Here's a clinical vignette. Which following anticoagulants are approved for use without parental anticoagulation lead-in therapy? Just give you a second to look at that. And so the answer is going to be B, rivaroxaban. And so rivaroxaban and apixaban can both be used up front for treatment of DVT without having unfractionated heparin or low molecular weight heparin first, lead-in therapy. Whereas dabigatran and edoxaban have to be initiated 5 to 10 days after one of those heparin products. And the reason is just because that's how the trials were done, and that's what the package label insert says. So my final slide is just some additional selection considerations. If you're dealing with how to choose, which agent, since they're all indicated. If you're treating something with cancer, then most people will use low molecular weight heparin, just because the studies with DOACs haven't been done very much in cancer patients. We talked about parental therapy. If your patient preference is to have a once-a-day medication, then think about rivaroxaban or edoxaban. If your patient has GI issues, bleeding, dyspepsia, think about apixaban. Dabigatran has some more dyspepsia and probably some higher GI bleeding risk. All of them are cleared to some extent renally, so you may want to consider warfarin therapy. And then, of course, cost and coverage needs to be taken into account. Okay, I'll stop there. Thanks.
Thanks.